Okay, so ladies and gentlemen, a very warm welcome to you in this series of OSI webinars that began last April. Can you believe it? Over 1 year of digital education with Mr. Samir Hamada and the OSI team. We're very grateful to Pharmacia Ophthalmics UK for supporting this evening's event. And we are hugely grateful to our fabulous panel, Mr. Brian Tompkins and Dr. Keyur Patel, who Samir will introduce in a little more detail. As I think many of you know, I'm very lucky to have worked with Samir at the Queen Victoria Hospital a number of years ago. I'm feeling quite old now. And he is a leader in everything he does in corneal ophthalmology. I'm going to hand over to Samir. As I say, if you'd like to use the chat function to chat with also Denise and myself, please do. And please use the Q&A function for any questions. Samir, thank you very much. It's over to you.
Thank you very much, Jill, for the introduction. Well, thanks OSI team, Jill, also Denise, and all the other hidden heroes helping us to get to this platform, doing more education. So OSI webinars paused a little bit, but now we're back, and back because we found there is a lot of things happen over the last year, and we're talking here today about dry eye journey, patient journey, and I think you probably a lot of you agree with me. Dry eye patient journey has changed a lot through the COVID and after COVID. And just like a simple things like we see different patterns, patients, the way we see the patients is now different. So change to us as a professional, change bash patients with the way they describe their symptoms. They're developing now new symptoms and new challenges to management. So that's why I would like to today to bring the topic of dry eye patient journey, how it changed now, what are we doing now to ensure that we ensure the right diagnostics, the right management of those patients. And that's when Brian and Keyur submitted their article to OSI magazine, and this was a part 1 and part 2 about their top tips or top 5 they can't do without. I felt this is very interesting because actually what they brought really a very specific tools that actually very relevant to the time we are now. Let's call it post-COVID or kind of back to near normality. And this is really, I think the whole thing COVID shaked us as to say, right, we probably need to adapt and adopt in new ways to manage and diagnose and manage those patients with dry. So without further delay, I just want to introduce my very dear speakers today. And I have to say that we know they are one of the top people, experts with expertise in dry eye management. They have the right tools. They have a long-term experience. But the more you need to know about, probably no need to introducing Brian, who's very well known to a lot of you. He's experienced independent practitioner, and he has his own practice in Northampton. He was the PCLA past president and extremely proactive on all various types, especially contact lenses, dry eye management, and so on. Well, I think there is a title for Brian is edutainer, which is fit him very well, I have to say. So yeah, I'm sure you'll agree on that later on throughout the webinar. And also, obviously, Brian is a key opinion leader and advisor to various societies and industries. So welcome, Brian, today. And I'm sure we're gonna listen to a lot of your top tips in diagnosing and managing dry eye. So cheers, first of all, right?
Right. Yeah, and cheers indeed. And of course, the importance of a non-alcoholic gin and tonic. Yes, they do exist.
Yeah. Even better water.
Yeah, hydration. See, hydration is there.
Exactly.
But you must give a massive shout out to Keyur as well. So
of course, yeah. So now moving to Keyur Patel, very well known to a lot of us. He is really award-winning optometrist. He's a director of the multi-award-winning practice, Tompkins Knight and Son Optometrist. Well, if you read about I was telling Keyur the other day, his titles really can fill the whole 2 lines easily, and you can add more and more. He definitely a key opinion leader and contributed to loads of journals and forums, sharing his experience, his knowledge on various aspects. He founded the iprescribe.info, and he is obviously, there's a lot of list of things I can't list everything, but definitely he has his print on management of dry eye, and he think a lot of times out of the box. And definitely when we have a chat on various occasions about kind of difficult cases, he impressed me with his knowledge and his expertise. So I couldn't find a better guest than Brian and Keyur. So welcome both today. And if I may start asking you about the patient journey, how do you find this change now? Do you find the dry eye patient come to you the same way you used to see them kind of pre-COVID, or things that change a bit now?
I think that we've been kind of watching out for dry eye symptoms and dry eye management for such a long time now, which, you know, certainly stemmed from our desire to make contact lens work more successful. I mean, really, probably until a few years ago, dry eye wasn't thought of as its own problem. And since the TFOS Dues 2 announcements, etc., that the process of it being a disease is so much better known now. And COVID, of course, has brought about so many interesting challenges. What are we doing now? We're all staring at a screen, watching things, forgetting to blink, and doing all the things that make anybody's tear system, which could be challenged from being indoors all day, even worse by just making the concentration levels, etc., harder. So, Kaya, you've kind of seen a lot more of the post-COVID stuff. So, what's your thinking?
I think people are more aware of it. I think we've had a whole year, like Brian has said, of people looking at screens. But what it's done, I think, is made a lot more people, not that they weren't, but a lot more people internet savvy about looking up things, looking up their symptoms. And this was pre-COVID anyway. You've got the people who self-diagnose, you know, via Dr. Google. And as more data comes out about dry eye, how it manifests, the effects it can have on how you feel, how you work, I think people have become more savvy to it. I think for us, you know, definitely over the last 6 months, we've had more people reaching out to us through at least initiating contact, because they've become aware that they're having problems. They're also aware now how stretched the NHS is and how difficult it is to get into a hospital clinic to have their symptoms managed. And interestingly, for me, I think actually for healthcare in the UK in general, is that people have actually gone, well, actually, I'm willing to invest in my care and go and see someone out of my own pocket rather than burdening the NHS with something that, like Brian said, up until relatively recently was, you know, kind of a brush of the hand. Oh, you've got dry eye, take drops kind of thing. We learn more about it. I think people are investing more in themselves, and we've been lucky. You know, historically, contact lens practice. We realized that a lot of the stuff we were doing to keep our patients in lenses is actually the stuff that the non-contact lens guys need to manage their dry eye. So for us, it was kind of a overlap. We kind of fell into it, but we just embraced it. So it's kind of double bubble, you know, two business elements for us in one, very overlapping. So for us, it worked quite well, but people are reaching out to us. We had to create a whole new email structure to allow people to get in touch with us. And from a business point of view, we've restructured how we did things in terms of making sure that we were advertising, making our presence really felt on the internet to differentiate us from other providers of care that are out there.
And also, really importantly, and you know, we will never shy away from the business aspects of things, and nor should any practitioner. We are not shy of charging properly for the services, for the elements of care that we give, for the time we spend, for the equipment we've invested in, etc. And as we do more, there are more and more people finding us from word of mouth, from social media advancements, from social media kind of contacts. And you will find that your business, and let's assume, I don't know what the kind of overall audience is, but assume, sorry, I've got my dog being a pain, so I'm going to feed him something. You know, if the audience is optoms that are independents, then if they want to make a name for the dry eye management things, then that investment becomes a business model care level. It gets something which allows for greater people coming through. And once you get a name, either in your area or in the UK generally, then more and more people will come through word of mouth or word of the internet, as Keyur says.
Excellent. No, thank you both. You know, I mean, you both brought many things in really few sentences. So actually, we agree, we see more patients. You brought the idea that actually your patients now are more educated because they read more, they look more. You talked about the challenges we see now, where some of us managed to adapt to the challenge, and there are opportunities. And I think many of us use those opportunities. And I think, Brian, you're talking about using the social media and all that. So great. There's so many things here. And I think before moving to your top tips, you talked about it. Can I just ask you, if you tell me like 2 or 3 really serious challenges or you faced, or at least 2 to 3 things that you change in your practice and you feel really made impact on your practice, because at the end, a lot of people here want to think, okay, I want to start a dry eye, or I want to enhance my dry eye practice. What things I can do to make it better?
Well, I think the first thing is have your team 100% behind what you're doing in every aspect of practice care. Mm-hmm. You know, the team have to understand there are special needs in dry eye, there are special needs in contact lens work, there are special needs in glaucoma, whatever the process might be. So having a really well-trained and up to speed and educated team is super crucial. Mm-hmm. And then you can start with the simplest. I mean, we're going to go on to some of the tools that we absolutely adore, but you can start with the simplistic thing of just using your own eyes and experience to look at a patient and understand. And I know that everybody that's in dry eye management in any way, shape or form is blown out by the kind of responses that we get from patients simply because we listen, simply because we allocate the time, and that time we get paid for, but people being able to tell us over the period, because our dry eye management appointment is often 2 hours, charged fully, but we still do over a 2-hour period sometimes. And just to have that dedicated time, which is really just not practical in some of the more clinical hospital-based scenarios, it's an opportunity for them to understand they're being investigated fully, understand that somebody is trying to get to grips. And I have a kind of a saying within the contact lens and the dry eye world: we will kind of never let go. We will do anything and everything in our power to make their lives better. And that is so crucial to some of these really seriously in trouble dry eye patients.
Excellent. Keyur, anything you want to add here?
I mean, I know Brian spoke about what we need to do as a practice. I think in terms of the one thing that I think that optometry has as an issue, in terms of what is a difficulty, is actually getting the general public to understand what we do. The GOC, just the General Optic Council, just did a survey, and only 1 in 3 people would go to their optometrist if they had an eye problem. And I think that says a lot about the profession, in that we have not, we've not set ourselves up in the correct light. No disrespect to my GP colleagues, they're fantastic. They do things I couldn't dream of, but they've spent 2 weeks in their hospital rotation. Then they are not perfectly placed to look at to manage eye issues. And same goes for my pharmacy colleagues. I wouldn't want to do what they do, and I think that's a big thing that the profession needs to work on. But what you can do, what we do, and this takes time, is educate the patient about what you can offer. And if you educate the patient about what you can offer, you'd be amazed at what they are prepared to give back in return.
Excellent.
The other huge thing is being sympathetic. But the more you get into dry eye management, the more complicated it gets, the further down the line you're doing things. Some of these guys, and ladies and gentlemen, and some of these people are significant issues, and you've got to be prepared to listen to them and hear what they have to say, because some of them have a lot to say, and your empathy, you have to bring out your empathy. It sounds strange, you know, we're all healthcare professionals, but you really have to bring it to the fore, because sometimes they're at the end of their tether. And because historically dry eyes just been throw drops at it, it really changes your way of thinking about how people feel.
That's amazing. Actually, you brought the essence of good patient experience, which is about you have the right team, you give the patient dedicated time. As you said, you spend 2 hours with patients, educating the patients, let them know about their condition. That will improve their compliance, obviously. They understand what we're talking about. And the sympathy, that's definitely key things, because they feel that actually you feel this, what they feel, and you try to help them. And I'm sure they feel that you are the one who try to help them, and then you get the positive feedback, and patients are really grateful to what you offer them. So let's go now to the more clinical a bit. So in your new article, Brian, when you started, you said, I have 5 things I can't do without when it comes to dry eye disease. So, and I think the 5 would fit very nicely with your patients sitting in a clinic with their journey. And I think it would be very nice if you listen to say, I am a dry eye patient, I'm coming to you guys, what are you going to do for me? And what are those 5 things talking about?
Well, I put together 5 very, very simple slides, and it's going to help us, Keyur and I, to kind of just start with a journey. And if I can just share my screen, it should come out. Let me just do this first. I'll play. Let me go there. That should be able to share now. I've got to find the screen. And let's just exit out of that one a minute. Let's go back there again. Finding the mouse when you try and do this is terrible. Right, okay, so let's go there, and now hopefully, right, hopefully you guys can see that.
Yes, we can.
Good. So this is, I mean, each of these tools happen to be ones that we have, but this is just an example of the technologies that exist now. And a lot of these technologies went way beyond where we were historically, even during COVID period. So we had a lot of advancements because the company sat at home, they couldn't go to conferences, etc. So they just carried on their development levels. And the point about these tools is that they are, okay, relatively advanced. You don't have to have every one of them. And every one of us in practice, ophthalmology, optometry, doesn't really matter, will start with this first element of thinking about that patient. We are absolutely super keen on branding. And so we've taken the OSDI form, we've taken a kind of screenshot of our practice management system. And these are 2 forms that we pre-send to any new patient or to any dry eye patient, to technically any patient coming through, so that we get like a preloaded idea about exactly what their concerns and difficulties are going to be. So we are asking every single question that we would, from medication to their history of what's going on. And we're kind of big believers in the OSDI. I know there are other dry eye questionnaires, etc., out there, but and I know many people like the speed and other factors, but we get a lot of information and data from OSDI. But the full questions list, which is sort of precede on the history form, gives us so much background. And what we do is we tend to examine the patient, often using one of the telemedicines, which we'll talk about a bit later. So we'll often have a video conference with the patient before they come to the practice, so we get an even greater understanding of their needs. Keyur, any more you can think of that's relevant?
Yeah, I mean, we're very lucky now. Pretty much everyone is internet savvy. There's not many people. There are a few, but there are not many now who can't access an email, download an attachment. And the nice thing about these forms and having them do them at home is that they can take their time. They can look up their meds rather than, well, I'm on 6 meds, something's blood pressure, something's cholesterol. You know, if they have family history, they can ask about it. They can come in really prepared. And at this time, particularly where we are in the world at the moment, it actually just means that it's a little bit less face-to-face time. So we're not, you know, we are protecting them, we are protecting our team, because they are not sitting there unnecessarily. And also there's not that kind of, you know, performance anxiety where you're sitting there trying to fill out a form thinking, oh my God, they're waiting for me, I need to rush. You can really sit there and fill it out at your pleasure and correctly. But Brian was mentioning about the OSDI. The reason we like it, it's obviously validated. TFOS due to recommend it as one of their go-to questionnaires. But there's a nice section, that middle block, where it talks about visual tasks, reading, driving at night, things like that. And for optometrists, this is really key. So what we do know now is that people who have binocular vision issues can present with dry eye symptoms. So we've seen patients who've gone, I've got dry eye. We've looked at their OSDI, it's very heavy in the middle. We've done tear breakup, we've looked at their glands, and we've gone, your dry eye is actually not that bad. We think you have a refractive problem or a binocular vision problem. And we've addressed that, and miraculously their dry eyes got better. So for us, that's a nice little indicator, because we can look at it. If someone comes in for a dry eye assessment, we will go, well, actually, let's just make sure their refraction is correct. Let's make sure their convergence is okay. Something that we do on a day-to-day basis. So it's pretty straightforward. That's why we really like it.
I like what you said here about the, to be honest, with that questionnaire, I would say to me why it's important, and now I agree with you, this is can't do without, because one, you are on the way to diagnosis, because if you look at the DUS2 report, you're gonna have a questionnaire, so that's a must. That's 1+1 sign. And the 2, actually, you are already on the way of the level 1 of the management of dry eye disease, that is educating patient, elimination and modification. So you see what medication they're using, their lifestyle and all that. So you already you probably have a plan to the patient before you even see them in your clinic, which is great.
Yeah, and obviously with everybody having been sat staring at screens for the last year, there is the dry eye element, and there is also the close work element, which is very much under investigated in many cases. And the 2 really link so closely that one of our absolute kind of essentials is to get the close and near and binocular vision absolutely spot on. And as Keyur says, often we've almost got rid of most of the dry eye symptoms by making the refraction and the comfort level for study, etc., or work day to day so much better. And we know that people are spending actually more time working at home than they did at the office, because they're not driving to the office, they're not getting up talking to their friends, they've got nothing better to do but stare at the screen all day.
Excellent. So sending questionnaire, Wahida here say this is an excellent idea to send questionnaires prior to appointment. Very good. Yeah, and I agree with that.
Hi Wahida. Hiya. The other factor, of course, with the OSDI is that we can take the pre-treatment measure, then put whatever measures in place that we need to, and then they do it again when they come back, and again when they come back after, either just purely hygiene, purely near vision's help, purely for IPL or any of the other factors that are there. And we get significant score changes when we can see a treatment that's really working. You've got some examples, Keyur, I think, of some IPL treatment scores that have gone dramatically better.
Yeah, yeah. And I mean, you know, with all this stuff, that unfortunately, there is no one magic pill that fixes everything. And I think that's where the TFOS Juice 2 report is, that, you know, their management and structure is really good, because it gives you that baseline and you can work on it, you can work on it, you can work it. And then as you work your way up, it becomes a little bit more complicated, a little bit more therapeutic, a little bit more prescribing, and people can build on it. What's also nice, I think, which is for us as optometrists, and hopefully for you as well, Samir, is that you know that if everyone's on the same path, the education to the patient has been the same, and you don't have people starting at, you know, at the top of the tree and totally ignoring the foundation. You know, they're not putting the roof on before they put the foundations in and putting the walls up.
Mm-hmm.
And so in terms of cross-professional, in terms of professionally, it's really good that we can cross over. Mm-hmm. And say, look, we've done stage 1, stage 2 management. We're, depending on where you are, we can do the limit. We're at the limit of what we can offer. We know the patient has good understanding. Can you please now take it forward from here?
Can we, I want to really spend some time on management, because I've got a lot of questions to you on management, something really, really practical. A lot of people want to know the answers to. So can we move a little bit with your top diagnostics first?
Sure.
And then we're going to move more about management, if that's okay.
Yeah. So this is all based still originally on us getting the absolute best option we can for a contact lens patient. So all of the questionnaires, etc., that we're doing, we'll do on every contact lens patient coming through the door. And one of the absolute necessities, certainly mentioned in TFOS Juice 2, is the osmolarity. So we've been very strongly invested in tear analysis to make sure that we can pick up any osmolarity changes. And we find a great benefit to looking at inflammatory and getting matrix metalloproteinase 9 measures prior to going to any form of lens or finding out any aspect of the patient's needs.
And do you do it routinely, Brian? For all
sorry, so yes, we do it routinely on every contact lens patient. Mm-hmm. We will often do it on a patient if they are exhibiting any of the stingy, burny eye symptoms that we might get. It's classically more used around hay fever time, so people coming in with the issues that are there. And okay, this is something that we've done, and not everybody can or wants to do this, but of course, about 6 months ago, we went totally private. So all of our patients now get any aspect of everything they want to do, because we really are paid properly by them to do everything. And so consequently, we will do these elements, maybe a small top up for some of the kind of things that cost, like the kit that we're working with here. But we'll have a much better understanding.
Mm-hmm. Sorry, I was thinking, did you feel there are cases where actually the MMP9 measurement really helped you in your management? Because a lot of people will say, I can pick up inflammation. I don't need MMP9 or the tear analysis to judge that. There are signs I can look at. Are there cases where you feel like actually without Infladry, I could not do without it, for example?
I think a lot of patients, I mean, Keyur, you know, let him say something in a minute, but ultimately, I see a lot of patients who don't know they're in trouble. And so we get an Inflammadry that actually it comes up as a positive. And when you really dig down into their symptoms, they're aware of maybe a bit of burning when they're just watching telly, and they think it's normal. We then treat that patient, and obviously this is linked in often to Demodex and other blepharitis issues, and often we'll treat that with whatever the method needs to be, either simple as Optimel, the honey drop, or as more complex as going into deep massage and hygiene, etc. measures.
Yeah. Yeah. Do you think this is something, a tool will help you to improve patient compliance? It's like when mammography, you show them, this is your glands, this is what you're missing. Now you show them a test like pregnancy test.
Yeah,
you have
that's how we describe it.
Look at it.
Well, it's like a lateral flow test, so everybody's used to doing lateral flows and things like that. So they're more keen. But no, I think it's been very useful. We started it initially if we were punctum plugging, because we didn't want to plug an eye that was then full of rubbish and junk. So we kind of started it that way, but it became so telltale of other problems that, you know, it's really part of our keen armory of things to do.
Mhm.
So I mean, maybe I know, you know, maybe we're cheating. Maybe there are non-testing ways of looking for inflammation. Maybe me and Brian are not good enough to seeing the really, really subtle stuff. But for, you know, for us, you know, when an eye is really inflamed, you're going to see it. But if it's subtly inflamed and you're doing all the other things around it, I think sometimes it's very easy to miss.
Mhm.
So maybe it's cheating. I have, you know, the people who can do it without this kind of kit, you know, I give them mad kudos, because you know, their skill set must be way above mine for the subtle things. But for us, it's great. It just, I mean, if I see an inflammatory eye and I see how red it is from a little bit to very red, I'm automatically thinking, can I get away with a over-the-counter homeopathic type medicine like Optimal, which is shown to have anti-inflammatory antibiotic properties? Or do I need to start getting out the prescribing pad and going for the FML or the DEXA-free, you know? So for us, we find it really useful. We really do.
Would you use it as a way also to know there's inflammation cured, or there's no more inflammation?
And yeah, because again, it's another teaching tool, right? Because when you can't see something, it's hard to appreciate it,
Mhm.
right? You have all I'm sure we've all had patients who have seen many people before, and they've been told time and time again they've got blepharitis, but they don't quite get it. You then show them a picture of their blepharitis, and they're like, "Oh my God, that's disgusting. How do I, you know, clean it now? I need to get rid of it." And those visual clues have huge bearing on compliance and outcome. And when you show people, you go, "Look, you've got better."
Mhm.
Sometimes they just need to see it, and then psychologically they're like, "Oh yeah, I feel better." You know, the test says I've got better, and it has significant bearing.
And it is that
I would
number.
say.
It is that test that says you are not as good as you could be, and you are better now. And it kind of education-wise, it massive help to compliance again.
Okay, cool.
So if we move on from that, shall we now?
Please. Yeah.
Well, no ophthalmology or optometry department or practice doesn't have a slit lamp. To me, I like to call it a slit lamp biomicroscope to a patient, because a slit lamp tells us what it is, because we kind of use it all the time. But a patient doesn't know what a slit lamp is. But if you say it's a microscope, then they understand what's going on. It's a really simple language thing, but it's really important. And I know that people say, "But I don't have a camera." And then I've worked with video stroke photographic digital slit lamp photography for 25 years. I cannot think of a time when I've not been able to utterly demonstrate to that patient the dirty contact lens, the mucky lids, the makeup in the way, the contact lens is moving around. It's a pure illustration. What's happened is, as technology has moved on and the digital aspects have got better and better and better and better, is of course we have now other ways to access digital analysis. So there are some fantastic photographic systems out there just by attaching your phone. So anybody that says, "I've got a slit lamp, but I don't have a camera," I bet you got a smartphone. Even if you hold it steady up to the eyepiece, you can get images. And the magic that that patient sees by looking at any aspect of care that we might be giving them, from a dirty lid to a Demodex tail sticking out of the lid, anything is illustrated so beautifully by the imagery. And so that picture paints 1,000 words is worth every aspect of education it's ever needed.
Agree. And to be honest, as a cornea specialist, we've been taught, when I was a fellow, I've been taught that you have to get your colors. You can see my camera, but you have to have those pencils with all the colors to make a nice drawing. Otherwise, you're not really describing perfectly well what you see. And that must be now very outdated, because I agree 100%. You need a digital photos. This is the way to monitor, to see the change in the lesion, especially when it comes something you can visualize it on the camera. There is no drawing. There's nothing can replace with it. And now with more, to be honest, the digital EPR systems, it's very easy to integrate all these digital photos on your system. So rather than make it drawings, you have the photos just to monitor the patients.
Yeah, and the patients love that. Often they'll ask for the image to be sent to them. Absolutely no issue. We can send to you guys as ophthalmologists, this is what we see. So it's referral, it's monitoring, it's comparing, it's looking year by year what may be happening to things. And of course, with some very clever advanced grading systems out there, which we're going to talk about a bit later, then those images that are taken by whatever clever digital system you have are further enhanced by grading scales that are now artificial intelligence. So really smart stuff.
And it's getting more and more competitive. I mean, digital imaging is getting more and more competitive. There was a time where you could only go to one or two of the manufacturers to get a product, and you paid the premium for that. Now, lots of products, very competitive market. So I know Brian mentioned the phone adapter, down and dirty. Put the phone up to the eyepiece and go with it. But if you're within your own practice, and shop around, that's what Google is there for. That's what these conferences are there for. Go and haggle, because these manufacturers know that there's competition. These manufacturers know that if they want to sell their product, they've got to give you a good product, but they've also got to give you the best price possible. Otherwise, you'll just go to the next booth and speak to them, because they'll be able to give you a product that does what it is. I mean, sometimes you don't need the most amazingly, stunningly bells and whistle camera if you're just looking to get, elementary stuff to follow through on your patients.
But Keyur, I was excited by your article, and I started to put order on a drone slit lamp. Are you going to tell us a bit about it? What is that?
So that actually, go on, Brian. Do you want to talk about it?
About innovation, right?
This is something we saw with the amazing. I saw it at an American talk with John Gelles over in the States. John's a great friend and a fantastic practitioner. And if anybody gets the chance to listen to him, he's really, really smart. But it's literally driven by technology. So you could be 5 miles away, you could be 100 miles away, you could be 1,000 miles away. And the slit lamp is then kind of driven by the remote control. It's like a drone. We've not seen one yet. If there is one available, Keyur and I could sit at home with a gin. One of our team could put the patient there and we could just see what was going on. Absolutely fine. I'm all for that.
Amazing. And I'll do surgery from my garden as well. That's good.
Shall we move on again?
Yes, please.
Lid and tear diagnostic kit has really gone massively clever. We have a particular piece of kit by a particular manufacturer, and obviously it's not difficult to read the screen there. And we kind of love this because it could be a one-stop shop for every aspect of looking at the patient, from non-invasive breakup time, which I think is genius, because to me, the traditional breakup time of putting fluorescein has always been flawed. Jenny Craig, great long-standing friend of mine, is now vice chair of TFOS, etc. And she said many, many moons ago when we were doing a workshop at BCLA, what are you putting in the eye when you put fluorescein? You're putting a drop of liquid with fluorescein in it, and that's immediately changed any aspect of residual tears that are there. So you're putting in artificial. So a breakup time, just to me, is a little bit outdated if you're using fluorescein. And to us, we find the non-invasive breakup time a huge benefit to our pre-fitting, and often actually over a contact lens, we get a lot of information as how much the breakup is happening over a surface, whether it be material, whether it be blink pattern, whatever it might be. And obviously this K5 bit of kit that we love is one, non-invasive breakup time is a very, very small part of the stuff we do. And it is a complete suite of analysis, and the Yenvis scale runs a really clever format, 1, 2, 3, 4, 5, 6, blah, 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 into the system of giving analysis, and it produces a report. And that again is a huge education tool for the patient.
Amazing. And it's part of what's the use recommendation, isn't it? About non-invasive tear breakup time and tear meniscus height, all that.
Yeah,
with Use too, they prefer non-invasive, but I think they're well aware that, you know, not everyone can afford it. You know, we're very lucky we're in developed country, first world country. You know, some of the guys who are out in the villages, in some of the less developed countries, as we like to call them, you know, for them, slit lamp is fluorescein is a good surrogate. But what you have to remember is that when you put that fluorescein in, you want a little bit of fluorescein, kind of the minimum amount of fluorescein you can put in just to get some in there. You don't want to be flooding the eye with fluorescein, because that's going to outrageously distort their tear breakup time. So the TFOS Use too, yeah, like it likes a non-invasive, but there is, you know, if you read the small print, there's a really small corner where it says, if you don't have it, use fluorescein, because having a breakup time is more important than not having anything.
But you're going to use fluorescein and lissamine and every aspect of stain to look at so many other aspects. It's not just the breakup time that fluorescein is super useful for. You know, there can be so many indications of.
But what I think, Brian, I think what they're trying to say is that just because you haven't got a K5 or a minor, or, you know, all these lovely new devices that are out, don't therefore just ignore it. Don't just step away from it. No. And I think what we have to educate our patients, is our colleagues and our friends, is that do it because it is important, but make sure you do it correctly. And so you can't go in with that, you know, the bendy end of the fluorescein strip just full of fluorescein, plop it onto the eye, because that's just not, that's really distorted. Whereas if you put a little bit in, yeah, we know it's not great, it's not ideal, but it works, you know, it makes it inclusive. So you're not saying to someone, you can't be in our tear breakup club because you haven't got a non-invasive breakup measuring machine.
Yeah, and one of the other things that is big investigation at the moment, of course, is mybography. Now, this particular device has a fantastic mybography capability and a grading scale linked to it. But Keyur and I, before we had this, we're looking at mybography in a huge variety of ways. You can flip a lid and look at the meibomian glands without infrared. But anybody that in modern optometry now, there's a lot more OCT available. We were even doing mybography reviews by doing the OCT and flipping the lid, using it completely off label, but still getting an infrared image of the meibomian glands, which gave us an indication of dropout or loss of gland efficiency.
Amazing. That's very good, actually. Yes.
Even a retinal camera, you know, would have some aspects of looking at the front of the eye. So if you've got any tool at all, don't just think of using it for its own device. Even, you know, taking an OCT image, you can do some anterior OCT things with lids and meniscus height and all sorts of things. So think outside the box, whatever device you have, and use it for things that it may not be even written up in the manufacturer's handbook.
Mm-hmm. Amazing. Right. What's your next one, Keyur or Brian?
The last one on this is, it's kind of the hinted that I said about digital imaging has gone even further into artificial intelligence. And We've been working closely with the AOS guys, the Advanced Ophthalmic System guys, and two elements of their kind of, well, three really, I guess. This is artificial grading or grading scales that takes no subjective element to it. This is graded by the computer. This is multifunctional. So Keyur and I occasionally disagree on things, not very often, but we do disagree on a few things. So we could both look at an image and look at the redness, the blood vessel structure, the whatever it might be, and we'd write down a grading scale, EFRON, CCLR, whatever it would be, and we might not agree. With this, we can both take the image, do the grading, and every single time it comes up with the same level. So in multi-functioning practices with multi-practitioners and multi-rooms, etc., this is just an amazing way to keep consistency. But during COVID, they developed it as a cloud platform. So we use this now regularly as an investigation to our patients prior to them coming in. This is the telemed system that we use. And we've had quite a number of emergencies sent through on the input system. So patients send an image in, we can analyze it and talk to them without them even leaving their homes. So this could be dry eye patients, it could be a contact lens emergency, it could be anybody that's just worried about a red eye.
Mm-hmm. And what we've actually done is we've incorporated it now that we're back in practice in our first communication with our new patients, particularly those special interest ones who maybe want complicated contact lenses, who have specific dry eye symptoms. For us, it helps build a rapport with the patient. They get to meet virtually the clinician they are more than likely to see. You know, there's something warm about seeing someone's face. I know we all talk about how Zoom is, you know, Zoom fatigue and things like that. Mm-hmm. But I'm pretty sure everyone who's joined us would rather be on a Zoom than on a phone call. And you can see so much, you know, we're as optometrists, ophthalmologists, we're a visual profession, and just looking at someone and making eye contact and just seeing where they are before they've even made it to you, we found really useful. I actually think our patients really like it. I think they're really happy that you know. Again, if we go talk from a business point of view, it's a big differentiator for us, because people are like, wow, they video called me.
Yeah, I mean, GP
pre-assess me.
Yeah, GPs are doing this naturally now. So a lot of GP visits have been stopped by video. And so why wouldn't we be doing exactly the same thing? This is not replacing clinical proper care. Mm-hmm. This isn't adjunct. This is an addition to. This is an advance to. And we get a lot of our specialist contact lens patients because of some of the features of contact lens work we can do, which we can go into another time. But ultimately, it's so useful for us to actually see the patient's face, to mm-hmm. see what their kind of frown lines are like. Are they deep browed? Are they deep set? Are their eyes too wide open? So you get a real understanding of that patient before they come through the door. You've got the questionnaires, you've got the video links, you've seen them, you've met them, and it's an instant rapport when they come through the door because you've already kind of met virtually.
Amazing. Thank you so much. Really, really useful tools, I have to say. So if I ask you, I know you can't do without the top five. If I'm an optometrist and I'm starting tomorrow, or ophthalmologist want to start my dry eye clinic, and would you say this is a good investment for future? Or would you say probably you can start with 2 or 3 of those tools and gradually build up? Or you think you cannot even have the practice without having those tools?
I think you can start with one. I think the first thing you need, irrespective of tools, is passion in here. Mm-hmm. If you are not going to be interested to put the time, the effort, and the education into yourself, mm-hmm. then you are not going to make an effective dry eye practitioner.
True.
If you put all that effort in, the patients will come. They will pay you good money if your charging system is right. And we could have a whole night on discussing fee structure. And if they come in and then put profit into your business, you can then invest in step 2 and then invest in step 3. And that's essentially what we did. Everything that we've done has been a gradual advancement because we've made enough practice profit that we could invest in the next step.
Amazing. Keyur, how, if I'm a patient coming to your clinic, I send my questionnaire in advance. How would the journey in the practice, how would it happen? Do you have someone like, do your technician help you?
Yeah.
Where are the steps? If just quickly, just so we know, imagine I'm coming to your practice, what I expect.
So we're a double practice, a 2 clinical room practice. So most days we're double testing, and you know, some of the kit that we have, we just can't afford to have 2 sets of it sitting around. So we'll have a clinical diagnostic technician who will collect the patient, will come in, get signed up, have a coffee. Diagnostic technician will come and collect them. They will do tear lab and inflammatory for us. And then once that set of testing is done, bring the patient to the appropriate clinician. For us, it just speeds up our flow. Also means that because we have a dedicated diagnostic suite, it's easier for us to schedule who's in there, when they're in there. Particularly now, it's a lot more wipe down and cleaning pre and post patient.
Mm-hmm.
So they'll come to us, they'll see a clinician. Clinician will spend however long they've been dedicated time. We will then go through a management plan, any kind of product that they may need, recommend, and if we have it, we will supply it to them.
Mm-hmm.
And then before we leave, we will make sure that they have our contact details so that they can get in touch with us for any kind of additional questions. And we have you know, you guys can see mine and Brian's emails. In general, we don't give those to our patients until we know them well enough that they're not going to harass us. But we created an email where Brian and I and Deborah, our colleagues, we just have access. We just have access to that, and we can just bounce it off, and then we'll walk them out. You know, give them their thing, schedule the follow-up appointment,
Sure.
and get them seen. Interesting. I think one of the pre-approved questions, I don't know if you're going to go through this, Samir, but they talked about how you schedule a follow-up. You know, how do you know when to schedule a follow-up? And I'm going to answer this one, Brian, because I've thought about the answer already. And it all goes with your management.
Mm-hmm.
So if you're gonna, if I'm gonna issue a steroid to someone who's never had any kind of steroid management before, we'll ask them to come in for 2 weeks just for a pressure check. Mm-hmm. Regardless, they'll just come in, we do the pressures, make sure they're not a responder, kick them on their way. If they're a responder, we'll deal with it at the time. But most people are not, in my experience, because I'm only using FMO. But there was a really interesting paper few weeks back, actually weird enough, by Jenny Craig and her team. And regardless of whatever you do, nothing really kicks in until 4 weeks. So you don't want to call them back before 4 weeks, mm-hmm. because nothing is going to change. And they did a really nice bit of work with Lyndon Jones and that whole crew about if you were to just use drops, it takes about 4 weeks. If you just did warm compresses, or if you do drops and warm compresses, it's about 3 months. Mm-hmm. So 4 weeks would probably be the soonest we would call anyone back. The longest would probably be about 2 months, mm-hmm. really. And then ongoing management, it then varies depending on what they need.
So I'm conscious of time, but I really want very, very brief answer from you, if that's okay, because we still have questions to ask you from the audience. One, if you tell me what's your top treatments. Patients nowadays, they're not patient, right? They want something works, give me the answer. I don't want to keep coming to you, because if I'm the one following use report, stage approach, etc., that's gonna patient coming, modification elimination, then we got mask massage, flaxseed oil, then come. It's a long process. Patient wants something more effective, straight answers. Do you have that magic? Maybe what your top ones in management you would, if you say?
My top one in management is education. because the first thing you have to educate them about is that there is no magic pill.
Yeah.
So we offer IPL, and we can do plugins, we can offer steroids, I can do orals, I can do all of that. But unless the patient understands that, well, firstly, we have to get to root cause is key. Secondly, as much as it is on me, it is on you. And if you do not do, if you buy the eye bag, but it just sits in your cupboard, or you get the drops, but you don't use them, there is no magic. This is chronic. And so I'd say the key is education. And that's why the imaging is really good, because you can show them.
Very amazing.
I mean, that stole exactly the words out of my mouth. The only way to make this work is for the patients to understand is down to them. And every management plan has different elements.
Yes.
Some may have lid whites, some may not. Some have heat and massage, some may not. Some go to IPL, some may not. And many times our patients are actually treated for dry eye management issues with contact lenses, because the right polymer and the right lens for the right patient is a joy to them. It's life-changing often.
Sure. So I can see Gel want to come with some more questions. We have questions sent to us beforehand, but let me just, can we just ask this question, Gel, first? There's two questions here I can see in front of me. So the first question say, when it comes to dry eye management and patients, a lot of them cannot afford the drops that are effective. GPs don't prescribe as it is not in their formulary, even when informed prescribe, and why. So the repeat prescription default to generic drops, as we know. How can this recurring problem be solved?
In my head, we go back to the whole education thing again, because a huge number of the dry eye patients I look after, I put drops as the last port of call. We'll give them simple, holistic, free advice on drink more water, eat more nutritional stuff, blink more often. The whole 30, 30, 30, 20, 20, 20, all of those rules, you have to educate the patient to look after themselves. And that would be our process of trying to get their own bodies as effective as they can be without having to put anything artificial in. Drops for us are a last case.
Are you saying, Brian, that actually it doesn't have to be more expensive to be more effective? Is that right?
Yeah.
Which I agree.
I'm just going to add to that, and this, I think this is another thing that we in the medical profession do. We do a lot. We seem to want to manage our patient's wallet. We don't know what's effective, what they're prepared to pay for, because we won't give them the option to say they can't pay for it. So we manage their wallets for them without actually saying, and we're very good at it in our practice. We will say, look, this is what it is. This is why you need to do it. This is your investment. And you have to, again, it boils down to education. If you don't educate them, a lot of people will buy cigarettes, but then not have enough money to buy eye drops.
Yeah.
Yes.
Can I just say I think for the question about the GPs, a lot of times what I do, we write in bold to GPs, say, can you please prescribe this? And we just give an explanation why I want this brand or this. There must be a reason. And that's also linked to another question about the preservatives, and because a lot of GPs will just change the prescription to preserve drops. So can you tell me briefly about the preservatives? I mean, are you always keen that everything has to be preservative free? That's a must.
Well, I was just going to make the point. I frequently get patients coming in saying, I have got drops which I put in 4 times a day, and they're artificial tears. Now, they're not even often preserved ones. I don't think we have any preserved artificial tears in the practice at all. We've got about 5 different brands of different types and different values of HA and all the other factors that are there. And to me, it seems crazy, whether preserved or unpreserved. I get the preserved thing, but unpreserved drops prescribed 4 times a day. What is the point? I will do it and educate the patient why, pre-task, mid-task, post-task. Do it when you're busy reading. Do it when you're just before you're going to drive, when you stop at lights if there's enough time, when you stop halfway through the journey. And it's managing the drop pattern, if they're needed, at the right way. And just putting an artificial tear 4 times a day, to me, just is crazy. So preserved, I would never.
I think also that there's so many more products now. I think again to use the excuse that preserved drops are that much more expensive than unpreserved drops is really a fallacy. I think there are so many very, very good products. You know, Jill sitting in front of a lovely sign of a very good product that comes in unpreserved formulary, which is, you know, a reasonable price point. If, you know.
Thank you. Jill, do you have some question before we conclude?
So actually, I was going to ask, we do have another question, but just on that note, I think as Keyur, Brian, and you know, Summer, I also work across the board with your Kiss Chris, other charities and societies, and this is a question that comes up so often with regards to preserved drops, price, cost, formulary, etc. And as you just said, Keyur, I mean, Pharmagea are this evening's supporters and sponsors of the meeting. And Denise and also both who work on OSI work with Pharmagea as well. And I'm sure they're sitting there with lots they'd like to say. But just to confirm Keyur's point there, you can pay a lot less for completely preservative-free drops and have a great result in a therapy or a treatment plan that includes many of the practices that Brian has spoke of, from drinking more water, blinking more often. And that is something that Pharmagea Ophthalmics promote very much, is that let's start with the natural therapy, the natural way of, you know, reducing dry eye. And then if you need some extra help, you know, vegan, preservative-free night ointment or daily dose unit preservative-free drops, then that's available as well. So I just wanted to say that. One question we did have from Wahida Ilai is, how would you encourage compliance to dry eye drops in younger patients? Are there any particular drops that you would use as a first-line treatment in children?
I'll go on. Shall I know? You know, Brian, you talk too much. I'm going. I'll cut you off there. I'll cut you off. Otherwise, you're going to be talking. People will be quiet.
I think you're probably going to say the same thing I am. Anyway,
I would probably go unit dose, to be honest, for kids. And I'd give them a bottle as well. I'd give them both. The unit dose for kids is nice. You can stick it in their pencil case. They can do it. And then if they lose a vial, it's not a whole month supply gone. Within schools, there's, you know, usually an issue now because teachers are not allowed to instill anything. And so that drop installation process has to be, you know, taken upon by the child. Unless it go to the nurse has to instill it. But you risk, you pay whatever, £13 for a bottle of, you know, the champagne of artificial tears, whatever it may be, and you don't want to lose it. So you go, this is the one you're going to keep at home. This is the one mummy and daddy are going to instill, because most of them are 60 to 90-day shelf life anyway. And we're also just going to give you these little ones. You put one in your pencil case, and I want you to, throughout the day, just put a drop in when they don't feel great.
I agree. Unit dose, but also I will say sprays as well. They quite like sprays, and I think schools very happy to use sprays more than just sticking something close to the eye.
I'm going to ask, maybe I'm being dumb here, but I don't think I've ever prescribed an artificial tear to a child, because their tear system is normally brilliant.
Are you forgetting some of your contact lens patients, Brian, who have some dry irritation?
No, not many.
Do I need to drop names?
Not many, because we're putting them in the lenses that actually enhance and help the tear film.
I agree. It's I think they do have dry eye, and if you ask a question like 10 years ago, do children have dry eye? People used to laugh and say no, of course not. But the reality is, yes, we see loads of cases, and certainly in my clinic I do a lot of pediatric cornea, and I see loads of cases with dry eye. It's just the compensation mechanism, the reflexes are better in children. That's why they don't manifest so many symptoms, and you don't see them until the really advanced stage where it is already damaged to the ocular surface. I think those where usually there's also comorbidity which made things worse. Sorry,
Samir, just to actually in support of Keyur again, with my mum head on, we have 5 children in this house, and I completely agree with Keyur that empowering your children, so 3 of the 5 children take a daily dose unit, as Keyur just said, in the pencil case or the lunchbox, and because we've empowered them to put that in themselves, it's resealable, 12 doses in a day. Thank you very much. And the youngest of the boys, who is 11, will remind us to put his night ointment in, because we've empowered them. And I think that's a really crucial point there, Keyur. Thank you for that.
Yeah, I just saw the question come up about, kids with blepharitis. Obviously, that's a very different story. But the trick with that is, obviously, we're treating the blepharitis as much as we are trying to keep the lubrication going. So once the blepharitis is often managed, there's less chance of the need, is my thinking. But
I'm glad Remy mentioned about kid blepharitis, and I will have a message. I hope many people hear it. It's very sad. I see so many cases of children present to the clinic with extremely bad surface, to cornea scarring, corneal neovascularization. No child should reach to that stage for a disease that could be managed early, to be honest. So a really open message, a child with watery eyes, photophobia, itchy eyes, they should be seen us. So it's sent to you guys, optometrists, to ophthalmologists. They can't shield also. Yeah, there's so many presentations, to be honest. And I think it's, unfortunately, the management of blepharitis in children, some people think it's just a mild and just a bit of drops and that's it. Those children go year and year, and then they end up with, I'm sure you've seen example, ulcers on the cornea and the vascularization and the lost vision, etc. Cases we should not see, to be honest.
Can I just, I won't, I just want to add one thing, is I think what, from particularly with our optometrist hats on, if you're seeing kids with blepharitis, you want to make sure that you've checked their refraction, because a lot of them have some kind of poor correction, and because they are not corrected properly, particularly uncorrected hyperopes are very prone to blepharitis, because they are always doing this, always doing that. So you see blepharitis in a kid, you want to make sure their refraction and their binocular vision status is on par, because I've seen a huge correlation between that, and there are papers about it, blepharitis and refractive status.
Excellent, thank you. Any more, Jill, from you?
So no, there's lots of feedback on those questions, lots of feedback saying thank you so much. The same with young adults, you're right about empowering people. Daily dose units are a great idea. Quite a few questions coming in for Pharmagea directly. Maybe they're not as known as some of the other products. And so we're going to play a short video at the end of this session just to tell you a little bit more about Pharmagea and how you can get in touch with them. It is my job as the host tonight to thank our industry support, because without financial support from our industry colleagues, we will not be able to run these webinars. So there will be a short video playing. It's quite interesting that we've actually grown participants during the Q&A and the last 10-15 minutes. So people are not getting bored by this Q&A, and they're extremely grateful for your answers. So Samir, before I close with the video, I'll hand back to you to just summarize and do your thank yous.
Right, okay, so thank you so much, first of all, because I think the journey is very clear now. I think the journey is obvious now. It's you, not only your patient journey, actually it's your journey, you and your patient, to educate them, to get them to the right tips you want to get. And using those tools you discussed are really, really important. And I certainly think I learned a lot tonight. So thank you so much. I mean, we could talk for hours and hours, and nothing better than this good discussion where actually you bring your real life experience, you see patients you see and all that into this hour. So again, I thank you for being here with us. I want to thank Pharmagea as well for their support as always. And I have to say, it's not about preservative free, and I invite all my colleagues, ophthalmology optometrists, to look at what's additive and buffers. It's not just about preservatives. And here, where I personally, there's no financial interest here, but I look at what the label, and without mentioning our sponsor, but they're probably one of the best products in terms of not much additives, which you probably don't know or hear much about it. So thank you very much. Thank the OSI team, and thank you, Jill, and I'll let you conclude. Thank you.
thank you once again. We've held the delegates, the panel. I'm not sure if you could hear me before. I think I might have just had an internet blip. But I wanted to thank Brian, Keyur, fabulous colleagues and friends, Sama, who I've worked with a long time, and Denise, and also at OSI magazine. You can see on the screen here how to contact Pharmagea website, who have been great supporters of tonight. And also any of the 5 tools that Brian and Keyur use, if anybody would like information on those, or would like
Jill, you've frozen. I don't know whether you can hear us or not.
I think Jill gone. Well, thank you, everyone. Jill, you back? No, I think she's gone. Thanks, everyone, and hopefully see you soon.
Thanks, Sama, for the invitation, and thanks for letting us sort of spout forth with some, hopefully, words of wisdom or advice.
Definitely.
Thank you. Thanks to everybody from us, and thanks to both of you, Brian and Keyur and Samir.
Well, next time it'll be in a bar, proper bar.
Yeah, properly. We'll set up a nice camera and do the whole sequence. So thanks again. Have a good evening, everybody, and thanks to
guys.
Dean as well.
Everyone.
Take care.
Good night. Bye-bye.
Bye-bye.